So should I get started with the intro? Okay. So welcome everyone. My name is Jessica Poliwata, and I'm a member of the Pegasus Institute programming team. I would like to firstly acknowledge that the land I'm located on is the traditional territory of many nations, including the Mississauga of the New Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. It is now home to many diverse First Nations, Inuit, and Métis peoples. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. This is the second episode of the Pegasus virtual event series. We are very grateful to be able to serve our community and for the continued support of our partners. Because of their generous support, we are able to present this program for free. These include Wilfrid Laurier University, the University of Waterloo, and the Social Sciences and Humanities Research Council, as well as the IPP-NW Canada. At Pegasus, our mission is to reduce disparities, inequities, and social injustices, and promote global health through the lens of peace and sustainability. The virtual seminar being presented today is the second of many to come out of the Pegasus conference. While our goal is primarily educational, we hope to connect people for action, including research, policy, and advocacy. We will be holding many more seminars in the upcoming year. Please feel free to contact Camille for more information and to be put on the mailing list. More information can also be found on the Pegasus website at pegasusconference.ca. For our event today, I want to encourage everyone to join the conversation. We want to make this as engaging and interactive as possible. You can also share your feedback and comments via our social media channels, such as Instagram, Facebook, and Twitter. Also, our presenter will be taking questions directly from our live audience. Ask your questions using the Q&A feature at the bottom of your Zoom screen. You can highlight questions by clicking the thumb icon to ensure we get to the most pressing questions. The theme of today's presentation is COVID-19 in humanitarian settings. Now I'm excited to welcome Dr. Paul Spiegel, the director of the Johns Hopkins Center for Humanitarian Health and professor of practice in the Department of International Health at the Johns Hopkins Bloomberg School of Public Health. Previously, Dr. Spiegel was the Deputy Director of the Division of Program Support and Management at UNHCR. Before joining the UN in 2002, Dr. Spiegel worked as a medical epidemiologist in the International Emergency and Refugee Health Branch at the Centers for Disease Control and Prevention. He is internationally recognized for his research on preventing and responding to complex humanitarian emergencies. We're thrilled to hear from him today. Welcome, Dr. Spiegel.
Great. Thank you very much, Jessica, for the kind introduction. And thanks to Neil and then the Pegasus Institute for the opportunity to speak with you. I am going to, my goal is to speak for about 45 minutes and then answer some questions. Jessica didn't mention, but I'm also a Canadian from Toronto originally, so it's always a pleasure to speak to a bunch of Canadians, as well as others I know who are online listening. So I will share my screen and hope that it will all work out. I may need a nod from someone just to say that you can see it. Can someone let me know if they can see it completely, the whole slides?
If you can, no, I can see the next slide window.
Okay, let me try. This is the usual. Here we go. Tell me about this. How about now?
It's full screen.
It's full screen now?
Yes.
Okay, excellent. Okay, so thanks everyone. Let me just actually start my thing. Okay, 1904. So I'm going to speak about COVID-19 in humanitarian settings, but this may be an unusual lecture because I'm not going to actually tell you what is happening, because currently we actually don't know a lot of what's happening. We know a little bit about what is being reported, but we are still in the dark, frankly, about many of the real situation of what's happening in these settings. But I'm going to try to paint a picture for you, and then I really look forward to some questions and answers. So I'll first start looking at COVID-19 and humanitarian settings. and that'll be the main part of this discussion, but then I want to talk a little bit about human rights and equity, particularly related to refugees, asylum seekers, economic migrants, but mostly those who are non-nationals. And then, should have changed, did it change? Yes, okay. And then I want to talk a little bit that it may be US centric, but I think it has implications globally, certainly in different parts of Europe, talking about some specific public health orders and asylum law that's been happening here on the southern border of the US. So I'll start now with COVID-19, and just to provide a little bit of background for those of you who are not as familiar. This is already sadly out of date. This was for the end of 2019, and the 2020 have not yet been released. But these are UNHCR figures. They're now well over 80 million forcibly displaced persons, and that's pretty important here. We're talking about forcibly displaced, not people who are voluntarily moving. Most people think about refugees, and the word refugee does have a very specific legal definition, but I think people use it very widely, understandably. But actually, there are about 26 million refugees, and there are 45, they say 45.7 or 46 million internally displaced persons. So not quite, but nearly double IDPs. And IDPs are people that have been forcibly displaced, but have not yet left or have not left their country. Whereas a refugee is a person that has crossed an internationally recognized border, fleeing generally persecution, and then has sought asylum in a third country, a country that is, a country that is not their own. You will see asylum seekers here, and asylum seekers are people that have left their country but are seeking asylum but have not yet been declared, have received refugee status. And then this is a very, very political, you can imagine in terms who is a refugee. So we have 3.6 million Venezuelans displaced abroad. This is a category that really I think many of us would say they are refugees. One of the reasons they're not, let's say, by UNHCR declared refugees is because of the situation and how they have been moving. In Venezuela, it's not a classic war violence. At least there is a lot of violence, sadly, perpetrated by the state, but not in this classic way of having two sides fight within a country. But I think for all intents and purposes, Venezuelans, certainly from my perspective, should be considered refugees. And sadly, it's increased since this time. So I expect in the new report that will come out, I hope in the next few months with UNHCR, not I hope, I think it's going to be sad that there will be certainly 82, possibly even more forcibly displaced persons. Now, I want to talk about COVID-19 and humanitarian settings. And OCHA, this is an OCHA site. OCHA is the Office of Coordination and Humanitarian Affairs. This, I believe I looked yesterday on, and it's a good site just to be able to see cases of COVID in areas of where there has been mostly conflict. And you can see the size of the bubbles relates to how many confirmed cases. What I can say, and you'll see throughout, is that this is surely an underestimate for a variety of reasons that we will talk about, but certainly access is one, insufficient tests. But there could be other reasons that we aren't entirely sure of at this point. So if you look, there are in these countries, and these are countries that have what are called humanitarian response plans. So they have plans that are out to be able to, for funding. And you can see there are about 3.5 million people of confirmed cases. And I imagine the number is much, much, much higher. But it gives you an idea, at least, of where some of these places are and what is happening. Excuse me. So what did we do early on? We were very concerned, I guess the whole global community is concerned that that refugees and internally displaced persons, particularly those in camps, are going to suffer disproportionately due to COVID for a variety of reasons that we'll discuss, but I think it would seem self-evident. So we worked at Hopkins with a group of modelers, with UNHCR, with WHO and some NGOs, to try to model what we thought would happen if, and this was early on, this was in March, so when an outbreak occurred in some of these refugee settings, what would actually happen. So let's looking at the Rohingya refugees in Bangladesh. I'm sure many of you know about them. One would have imagined, now the population that we looked at was the mega camp Kutupalong of approximately 600,000 people, but overall there are over 1 million refugees in this area, the Rohingya, who are also considered stateless. We assumed a high potential for transmission for a variety of reasons. You can see specifically the density, which is incredibly high. We then wanted to look at other aspects of, the idea was to say, this is what could happen if there are no interventions, and then to try to use standards, mixtures of sphere standards, which are standards for humanitarian emergencies, and other standards to allow the United Nations and the NGOs and the government of Bangladesh to plan appropriately. So what we did is, if you look at here at Kutupalong, Balakali, we measured 3 different transmissions or R-naughts. The red is the high transmission of what we thought would actually occur in this situation. And we had some reason to think that because there was actually a diphtheria outbreak, and the R-naught, the transmission rate, was actually higher than was expected during that time. And if this had occurred, we would have projected once the first case occurs with a high transmission rate of approximately 590,000 out of 625,000. So nearly everyone was going to be infected. And the projected deaths were 2,880. And I'm going to get to that because early on, most people said, well, that seems relatively a small number of deaths relative to the population. Then we looked at a moderate transmission, which is in the blue, and then we looked at a low transmission, which was in the green. And the blue would have been what was occurring at the time in China, and then the low transmission scenario was more in a flu-like season. And again, remember this was early on, so it was primarily China. We had some data at that time from China and Europe. So I want to look at just purely from a demographic point of view. I want to show you the estimating disease according to age and then the severity of the disease. So if you look to my left, you can see the proportion and the age distribution in the camps. That's to the left, that's the purple. I hope it's coming out well, the colors. That's in the Kutupalong, the Rohingya. Then you look at the pyramid, the population age pyramid in Bangladesh, and then you look in China. So it's just a massive difference, and perhaps not surprising, because in many refugee settings, particularly in refugee camps, there's a disproportionate amount of women and children. And again, it's what is interesting is then it's purely mathematical from the data that we had mostly from China and Europe, and we see on the bottom chart there in the blue, you can see that you can see clearly that the older populations suffer much more severe disease and have a higher death rate, mortality rate, and that has not changed from what we can see. It seems to be across most countries, if not all countries. But because of that, when you look at the proportion of severe cases, and you look now on S3, figure S3, you can see that in the orange or the yellow, you can see the proportion of severe cases amongst the Rohingya are significantly lower than Bangladesh, China, US, Switzerland, and Italy. And again, this was just using existing transmission rates at that time and comparing population demographics. So then what we tried to do was to look at existing healthcare capacity as it was, and where it would go with a surge, and the NGOs and the UN and the government were already planning to increase the numbers of beds and testing, et cetera. So what we wanted to do was look at the idea was not just to say this is going to be bad, but we wanted to estimate the numbers of infections, and then people could look at, well, what would the numbers of PPE need? What would the staffing be? What would the beds need to be? And in terms of numbers to be able to help this, to respond. So if you look at the, now someone can say, hopefully, I think you can see my cursor here. And if you look at high here, you can see high there after 58 days with the 95% confidence interval, 43 and 79, all of the beds, there were 340 at that time, from the first case would have been occupied. And then there had been a surge capacity, so they nearly doubled the beds, and then it would have increased, but not by much, from 58 to 61. So we were predicting a very, very serious situation. What are some of the interventions that have been done and that we also had expected and recommended to be done? So of course, there's the COVID-19. I like to divide this between the COVID-19 specific and the sensitive. And the specific mean it's COVID-19 that you do something that will immediately reduce transmission. And the COVID-19 specific interventions can be social distancing, physical distancing. It could be looking at task shifting, which would mean because you're going to have so many severe cases, many of the well-trained health professionals may be dealing with them, and you may need to be able to have either some of the nurses or even some of the community health workers task shifting and taking care of some of the COVID, either the mild or the moderate cases, where normally that would not be the case, and you would have a different type of health professional dealing with this. Some of the COVID-19 sensitive areas are what can we do that is already happening in the camps, such as general food distribution, and how can we try to reduce the congregation of people. So looking at general food distributions, there were lots of ways, and I think with World Food Program, they decentralized some of the distribution points, and they actually started to give people times and hours to come and to try to reduce the amount of queuing that would occur. There are many, many other ways to do this. And a lot of countries have done this now, actually. So for non-communicable diseases, as opposed to giving a month's medication, they may give 3 months. And I'll get to, that's a good idea, but let's see what happens in terms of the outcomes. And then there are always some cross-cutting fundamental issues with refugees, and that's protection. How can we ensure, and we've been reading, everyone's been reading across the globe, and this is what has been so interesting to me, is so much of what we work with normally in Congo and other areas in South Sudan, they're often worse there. And then when we look in Canada or the US and Europe, there are differences. And what's been interesting to me, at least, is to see that many of the same issues that we've been dealing with for years, such as an increase in sexual and gender-based violence and intimate partner violence, are of course occurring now with COVID as well. One of the big concerns that we have, and we are seeing it across the world, but for example, in Ebola in West Africa and then in Eastern DRC, is we saw increase of deaths due to excess morbidity and mortality of diseases that would normally be controlled. And malaria is a good example there, where there were more deaths in West Africa and Eastern DRC from malaria than there were from Ebola. So already thinking ahead of time of how can we try to reduce what we know will be disruption in services? How can we make sure that women are able to have safe deliveries, receive antenatal care across the board? So these are all things that we're trying to work on with the various organizations. And then on top of everything else, and I think I'll show the next slides show this, there had already been pre-COVID, you're of course all aware, the increase in xenophobia, populism, the increase in stigma and discrimination against migrants, against refugees, against asylum seekers. And sadly, when we wrote this at this point, and it was published, I think in April or May, a lot of the public orders were just getting started now, and this will be closer to the end of my lecture, but how governments have been abusing public health and public health orders for political reasons, and particularly for xenophobia and anti-migrants. So these were some of the issues that were coming up. How do you physically distance in a refugee camp where you have such incredible density? There were, and we've got to give a lot of credit to, before cases were starting, and even from the early cases, Bangladesh and UNHCR, WHO, and all the NGOs worked together. They developed isolation and treatment centers, as you can see here. They brought in 2 PCR machines, mobile PCR machines, to make a difference. So they were preparing. So what actually happened? I have 2 slides to show you. It's a bit confusing, to be honest. Early on, if you look at the right, the graph to the right, you can see the amount of tests, and these are week 0 is January, all the way up to I think it's last week, or a couple weeks ago. But I got this off the web just today, I think. So these are the number of tests, and if you look, that's the orange, and then the numbers of cases are extremely low in blue. And up until early on, you see very, very, very few cases. And then there was a bit of an increase around week 20, and then the testing went down, 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 and then it went in, and then it increased again. But there's been the numbers of tests have been relatively low to the population. And then surprisingly still, the numbers of positive tests are quite low. And then here you can see, and forgive me, it's much better to have rates, or at least ratios of numbers of people per 100,000. I wasn't able to get this from the website, but you can see in the next slide will show quite a difference between the host community and the Rohingyas, the Bangladeshis surrounding the camps in Cox's Bazar, and the Rohingyas. And what I don't know are the population. I don't know the difference between, but I believe there are more in the host community than the Rohingya, but not by this difference that you're seeing of there have been fewer tests, positive tests, there have been fewer cases, and fewer deaths. Now, if you look at this, and this was, let me just go back and show you. Yes, this is a really wonderful dashboard. If you get the opportunity, I'll share these slides with the PEGASUS Institute, but this online has very up-to-date information. This is just an example, again, to reinforce the point of looking at, these were the positivity tests, and you can see amongst the host community, significantly more positivity than there were and are amongst the Rohingya. So what we did is we provided with UNHCR for camps, we gave over 200 models for the refugees and IDP camps in 29 countries. And for those of you that are modelers, of which I'm not, we use the COVID scenario pipeline, and I have this links for you. So these were used at least early on to allow to using the latest data and the suppositions, because we didn't have data on the ground, to allow people to prepare. With this, we came up with a lot of issues that were, for example, what was feasible or is feasible in these settings, and how effective can they be when you're looking at physical distancing, quarantining, home isolation, shielding, masks. There's still a lot of questions, but I'll discuss that a little bit about what is feasible and what's not. But currently, we for the non-pharmaceutical interventions. So have there been major outbreaks thus far? I think the question is, we don't know at this point. There are, my next slide, I'll tell you a little bit more about some of the qualitative work that has been done. But speaking with WHO, and there have been no, to my knowledge, I hope maybe someone can tell me I'm wrong, but there have not been seroprevalence surveys yet in these populations. WHO and the Bangladesh government is actually planning to do one amongst the Rohingya. We have been looking at similar situations across the board, and speaking with WHO. There have been examples where in a slum in India, it was over 50% seroprevalence, but then in a slum elsewhere, not that far away, there was not a very high seroprevalence. And from the data that I've seen from WHO, There, even within a similar situation, the seroprevalence seems to be can be quite different. And there are a lot of reasons why, one of them certainly being the quality of either the way that surveys were done, because a lot of these are being now, as we know, before being peer reviewed, are already being put online. But from what I gather from WHO, not just in the humanitarian settings, but in many low and middle income countries, it's very unclear, likely because of a stochastic way of transmission. It's just not if you have a high R naught of a transmission rate, it's going to go through the whole population or not. I think it's much more complicated than that. So are we not seeing it? Because what we are seeing are reported cases. Because we don't have a population sero-based prevalence survey, we really don't know what is happening. And is it possible, and I think it could be, in many of these situations, you have a very, very young population, that there's been a lot of transmission. But the hard part is, and you wouldn't expect a huge amount of serious cases. And as we said, over time, maybe 2,000, 3,000 deaths, which is a lot, of course. But even in the Rohingya camps, if there had been a lot of transmission, we would have expected significant increase in visits to the health centers, hospitalizations, and deaths. And we haven't been able to record that as either. And so it's really unclear what is happening. And then the question is, well, what will happen, and will things change? And there are a lot of reasons of why this may not be occurring, and I'll discuss. But I wanted to briefly talk about this report, which was from IOM, the International Organization for Migration, and it came out, July 13th. This was a more qualitative, so we can't, we have to be careful here, but it was certainly clear when they were meeting primarily with block leaders doing qualitative work, that they claimed, and this was a huge part of the 1 million people that in the blocks that they went to, that there were more cases that were symptomatic, and there were even some deaths that were buried elsewhere. Excuse me. And the reason why they did not want to go to the health centers was, number one, there were rumors, and sadly, the Bangladesh government has now, although they've been very generous, they've now talked again about relocating people from Cox's Bazar to an island off the coast. There were rumors that if anyone was found to be positive, they would immediately be moved to that island. There was also a problem of the tests were taking a long time. If you went to the health center and were considered as a possibility and you had a test, you were immediately taken from your family and put into an isolation center, which is not brilliant for a variety of reasons from a public health standpoint, but also it's always this issue of when you start saying we're going to remove you from your family, and it's not unusual, it's happened in many countries. There's a tremendous amount of people that say I don't want that, and then they will not come forward. So this is still out there. I don't think we know the whole situation of what's happening, but how can we really know what's happening? Well, we can start with better surveillance data. We have gone over in detail now 2 or 3 different refugee-like settings, the COVID-19 data. And there is a much more stringent way of collecting the data, ensuring, doing contact tracing. And as we've seen in DRC and other places where there have been very few COVID cases, but they're used to doing contact tracing. And it's the same in many of these refugee camp-like settings, even though most people are out of camp, and it's a much more complicated situation there. So much better surveillance data and doing it well. Most of the data that we've seen, we've not been able to interpret well. Better mortality data, and it can't just be facility-based data. We really need to get much more into the community data, and also look at a little bit outside of the community and where people may be burying their dead for the reasons of not wanting to be found. We need risk communication studies. We need to better understand what are people doing, how have the way they have been moving, going to markets, how they've been interacting, what have they done to actually either make a difference or not in the way transmission will occur, We have very, very little data on that at this point, particularly in slums and in camp-like settings. And I put them together because of the incredible high density. We don't yet have serological studies. Those are going to be hugely important. We're in the midst of hopefully with some others of getting grants to do those. And then we need a much better improved monitoring and evaluation system, because as we're seeing with some of the long haulers and some of the, so there's the direct COVID effects of even if people don't have serious symptoms, they may have some long and moderate and long symptoms from COVID directly, but also everyone is talking about it, but we're seeing a massive reduction in the numbers of people going to the health centers and to the hospitals. We're seeing now, as I mentioned, people getting medication for 3 months. What is happening? What are the outcomes? Has there been increase in maternal mortality? Has there been an increase in malaria? What is happening with all the immunizations? So there are these secondary effects, indirect effects due to COVID, that are going to have both immediate and longer term implications. So that is my discussion on COVID and humanitarian settings. It's the same in Yemen. We had a webinar a while back where we had the WHO representative of Yemen. We've also been discussing with Syria what's happening in Idlib and other areas. It's really difficult to really understand what's happening at this point due to access, due to lack of tests. So at this point, sadly, we don't have a very good idea of what's happening. I want to move a little bit on to now human rights and equity, and particularly looking at refugees and then refugees, non-nationals, and vaccinations. So there's been no question that we've seen already tensions between increasing, and there are always tensions between refugees and IDPs in the host communities, even if they're the same ethnic group, even if they're cousins. After a long period of time, in many, many situations still, although we're trying to get away from it, those refugees and IDPs in the international community help them often significantly more than the surrounding population. And over time, it becomes burdensome and a feeling of unfairness by the host communities. So we've seen this already increasing, and particularly in Colombia and other areas, we've seen now increasing resentment of refugees and internally displaced persons due to COVID, but also due to a lot of misinformation that refugees and asylum seekers are spreading COVID. And we'll talk a little bit about in the US how likely it was the opposite there. And Antonio Guterres, the Secretary General, had mentioned this idea of a pandemic-related hate and xenophobia. It's happening across the board, and obviously with the current administration, we've seen it in spades in the United States. So we're likely going to, even as I'm speaking now, we'll expect approval by OFDA for a vaccine, for the Pfizer vaccine. I believe Canada approved it yesterday. There's a big concern still already. This always happens, but to be able to see it in real time, where you see Western or high-income countries already buying up much of the vaccine, we knew that there was going to be an equity problem for low income and middle income countries, and that's going to play out very, very starkly over the next 6 months to a year. But there's even another problem, is that for non-nationals, when there's a scarcity of something like a vaccine, yet you have in the United States and many parts of Europe, a large number of undocumented migrants all over South Africa. What's going to happen to them? And from a public health point of view, because the government is going to probably naturally favor their citizens, what is going to happen from a public health point of view when you have a group of undocumented migrants and or refugees or potentially IDPs, even though they're nationals of that country? It's still going to be able to harbor transmission. So that's going to be problematic. We had a discussion, so a webinar, I think it was yesterday. I think we all have so many webinars where the COVAX facility, which is with WHO, Gavi, and a big group of people, they will have a buffer of stocks that will be specifically for humanitarian populations. I think today or tomorrow there's a discussion on this, but how many there will be and for how long and how long will it take for them to get, we're going to see. And then on top of that, for many of these low-income countries, to have 2 doses and keep the cold chain at minus 80 degrees Celsius is going to be incredibly complicated. So I think a lot of people are talking about this issue of equity and recognizing it in terms of the vaccine in particular, but it will be the same thing in terms of treatment of COVID treatments. I believe, even though people are talking about it, it's not going to play out in the same way because of governments' perhaps understandable way of saying, I'm going to get this and wealthy governments are going to give it to their people first. So we did a global call to action with the Lancet, and it's been cited a fair bit, but I must say we do this a lot just to get the word out. But I think a lot of the times it's of like-minded people that are interested in reading this, and I do question, even though I'm happy that we get these out. This is something called Lancet Migration, which is a relatively new group of us that are looking at migrants and refugees, but with a focus on migration. But whether it actually makes a difference and has an effect from a political point of view, and will actually make a difference in terms of getting care to these populations or vaccines, we shall see. This will be my close to last. How am I doing on time? 39 minutes. I want to talk a little bit about public health orders and asylum law, because we, not surprisingly, knew something like this would happen. But we've seen governments across the world use COVID-19 and use public health as an excuse to reduce migration and asylum. So this is an example in the United States. March 20th of 2020, the US government, actually was a CDC order, which was even more disturbing. They stopped movement along the southern and actually the northern border in Canada, but Canada did the same thing at the time. But what the US did here is they still, on the southern border, they allowed, understandably, they allowed Americans and they allowed green card holders, they allowed commercial traffic to be going through because of, for economic reasons. And so in the end, this order stopped migrants from crossing from Mexico, and they're not, of course, nearly Mexican, they're often from the Northern Triangle countries, coming over from Mexico into the US. Now that had major implications, and UNHCR, the High Commissioner for Refugees, International Organization for Migration, everyone came out and said, it's not black or white like this. You have people that are fleeing and seeking asylum, and if they can't get into a safe place, of which Mexico is not, they can be killed. Their lives will be, they'll be killed, and US and other countries have international obligations to accept asylum seekers. That was stopped. Not only that, but then they started to arrest more and more migrants, and they started to fly them home, particularly to Guatemala. And unfortunately, which was clear, and they use this as a public health, as we don't want people bringing in COVID across the border. But the epidemic, the pandemic at that time was much, much worse in the United States than it is and still is in many of these countries. But by flying home plane loads of Guatemalans, there's no question that now, whether it started or whether it exacerbated the COVID epidemic in Guatemala, it certainly had an effect, and that's being more and more recorded. And then in July of this year, there was a Federal Register, which is before something can become an order, that it's out in the Federal Register, and the public has a certain amount of days to reply. And I'm not sure where this is now, but this was taking it to the next step to say, in the future, we want to have, and it was not going to be HHS, the Ministries of Health, it was going to be the Homeland Security, that was going to have the possibility of declaring when a disease became an increase in prevalence, and they didn't say what it was, they could stop people from coming over into the US. So they were thinking ahead and preempting how to reduce migration in the future. So here I don't, again, whether it had an effect or not, but we, a bunch of public health experts, we all got together with Human Rights First, which is a group here working on these issues. And we did write both to Robert Redfield, head of CDC, and the acting head of the Department of Homeland Security, to say that what you're doing doesn't make sense from a public health point of view. What we have, and so we went wide on this to be able to try to explain what the situation was. I think with certain administrations, and certainly with the Trump administration, they weren't going to be changing what they were doing. But the positive thing, at least from here, is that we are already working and trying to develop briefing notes for the Biden administration, and we've learned so much over the last, particularly since COVID, and they're obviously going to be much more amenable to many of the recommendations that we as a group of public health practitioners will be suggesting. I wanted to, close to end, I have 2 more slides. I wanted to just mention that one of the things that we have been difficult is having guidance just for COVID itself is complicated, as we all know, because of the new virus. We're learning so much, things are changing. It's even more complicated for a humanitarian setting because of the context specific and issues of security and protection issues. So we got together with 2 other universities, the London School of Hygiene and Tropical Medicine and the Geneva Center for Humanitarian Studies. And we put together this website where we had where we have all the latest guidance that relate to COVID and humanitarian settings. But what we hoped and we thought would be even more interesting is then we started to interview people and using a standardized forum all over the world, NGOs, primarily NGOs, trying to understand what they were doing, how were they using and innovating and revising the guidance according to their specific context. And then we would then upload that. At the beginning, anyone can do this and go on, but we found that for the most part, people weren't doing it unless we sort of contacted and said, can we interview, write this up for you and get your approval. So this website exists, and it's really meant to be able to learn quickly from the field, but bring it back to a global community where anyone that has a desire can click on a country, and then they can see what area, from triage to gender-based violence, people, how they are using guidance in the field in their own context. So the last slide, some last thoughts. Sadly, we still don't know much about SARS-CoV-2 and COVID-19, I would say in general. Of course, I think we're all living it, but particularly in humanitarian settings, there's a huge amount that we still do not know. It has been frustrating for those of us that want to try to use data to try to better understand. There's been a lot of, it's sensitive data, and both from governments and UN agencies, and so we haven't been able to, in principle, we're starting now to get some of the data. We're getting more and more data sharing agreements, but also the types of data, and particularly for COVID and COVID line lists, have been insufficient. And that's a pity, because that doesn't need to be, particularly early on when there was enough time to be able to gather the data correctly to try to better understand. We need to mitigate the indirect health consequences of the pandemic. I think people are aware of it, but I'm quite certain, particularly in many of these low-income countries where COVID has not had the same effects that we're aware of as they have in high-income countries, that some of the negative effects of the indirect effects are going to be quite high. we need to have open, overt discussions on the future treatments and on vaccines, and it's going to be not easy, and it's going to be primarily due to a lack of vaccine and wealthier countries buying up for their own populations. But we need to have an open conversation and advocate for some sort of equity. And finally, we need some sustained advocacy to try to stop the abuse of public health orders. It hasn't been here, it only been in the United States. It's been in many, many countries, Venezuela, many parts in Europe that we're aware of, some other areas in Singapore and others where they've been focusing on migrants. So I think I will end there, and there's various acknowledgements that you can read. This certainly was not all of my work. It's been a group effort. We still have a long way to go. Now more and more of these grants are becoming available, and we've already started some, and we'll continue to do research to try to better understand how COVID's been affecting populations affected by humanitarian emergencies. Great, I'm going to stop sharing now. If I can figure out how, give me one sec. Yep. Great. Can you see me now?
Yep, that's great. No, thank you, Paul. Whenever I've heard you speak, I've always been blown away. This time you've got information topical right up to today, as usual, and very relevant. And I noticed that whenever I have a clever question in the back of my mind, with you, I always either see the question asked like a minute or two later, or you answer that, something that I thought was unanswerable. So you've got a wealth of knowledge and experience, but it's great that you also allowed us to have other participants present. We actually have a very informed audience. People are texting me too while things go on. A lot of people with international experience with international NGOs. People have been in the field with different organizations, some engaged students, academics. And so I'm going to try to bring some questions together. We have 7 questions in the chat box thus far. So I'll just encourage people to use the Q&A, not the chat. Apparently somebody told me the chat has been disabled, but if you've got questions or comments, please put that in the Q&A. Because of the number of people that we have, we didn't want to unmute microphones for people because sometimes you can get distortions. So, so please put the questions in the chat box. I will try to bring a few questions together for Paul, just to try to simplify things. So I may start off with some questions from Nardin and about the number of cases here, as well as there was another question about rates in refugee populations compared to host communities. So talking specifically about the Cox's Bazar situation and why that might be, whether this could be related to host factors too, other than just the age distribution. And some people even are asking questions about the immune system and populations with chronically suppressed immune systems being protective. So maybe you could answer a few questions around that, about comparison data between populations, refugee populations and host communities, and then immunity type things first.
Sure. So I guess a couple different things. Number one is we often talk about refugee camps and or IDP camps, and that is very, very, it's much easier, which is probably why we do it, because they're circumscribed, you have people registered. But I think it's really important to mention that well over the 50% of refugees in particular are outside of camps. And the data there are even more sparse. So we're looking at, for example, we hope in the future to be working with HCR to look at some of this in Jordan, for example, and what's happening. You have two major camps, Atri and Azraq, but you have many, many, many more people, Syrians within Jordan and Amman and many other areas. And we don't have very good data for them. So that's number one. So in the Rohingya, and we're not just looking at the Rohingya, we're also have been looking at many other camps, but the Rohingya are number one of the largest camps, although there are some others in Uganda and elsewhere. But the data are strong in terms of knowing who gets tested. But the problem, and so why I'm hesitating a bit, is because it's clear in Cox's Bazar that it was from almost day one when the first cases occurred that the nationals, the Bangladeshis in Cox's Bazar, have a higher rate of infection. They have a higher rate of test positivity, and they have a higher death rate. Although even within Cox's Bazar, it went to the area, exploded to the areas, to the levels that we had even expected. Which then brings us to the next question of why. And I'll just say we have been following with UNHCR and looking at other camps. To our knowledge, there has not been a massive outbreak as we had expected and as our models would have predicted. And that doesn't mean that there hasn't been wide-scale transmission, but there does not appear to have been wide-scale severe cases that have been hospitalized and large numbers of deaths that were expected. So why is that? The easy answer is we don't know. There are a lot of suppositions, everything from someone mentioned it could have been exposure to other coronaviruses. There's no evidence for that yet. Could there be immunosuppression, particularly amongst people who are acutely malnourished? There are a lot of questions that people really don't know at this point. That's number one. Number two is when we look at the transmission, there are also some other issues that may come about, either in some cases, like we said, in both in Dhaka and then in some areas of India, we've seen very high transmission. In others, we've seen very low transmission. Most of these in refugee settings are people living outside. Yes, they're living in huts of some sort, but even those are quite well aerated. But when they're outside and they're mostly living outdoors and outside, and we know how dramatically that reduces transmission. So I don't think we know enough yet to really understand why. And I'll just end by saying what's strange is that we're not yet aware of some of these massive super spreader events that we've seen in other places. But there was an uptick in cases after Ramadan in the camps in Bangladesh, but again, not to the extent that we would have expected.
Okay, thank you. Actually, I may just follow up that with a question regarding measurement of excess mortality, and particularly if you have policy measures, whether it be physical distancing or you have laws restricting certain things. I would think that the contextual types of things may be difficult to sort out from the COVID-associated mortality, more so in refugee camp situations than in a country like Canada. Just wonder if you could speak to how you would be conducting the excess mortality studies.
Sure. It's in a way what you were saying is, so what we're looking at, what we're planning to do, and we are planning to do this. Interesting, we're planning to do it and we hope starting in January, in Cox's Bazar, but not amongst the refugees, among the Bangladeshis, in Bangui, in Central African Republic, and in Eastern DRC. So we're planning to do a couple different things. Number one is documenting the policies that were implemented. For example, was there a quarantine? Was there isolation? what were the policies that the government put in, and did the people follow them? And how we'll be doing that will be mostly qualitative in nature. We'll be looking at, in some of these places, they have a government health information system, the DHIS2. So we're going to be trying to examine all of the data, the surveillance health center surveillance data, pre and post COVID, 2 years previous, and then starting from January. And we'll be looking at everything from the numbers of people coming to the clinics to incidence of malaria with rapid diagnostic tests, and we're going to start to be comparing before and after. And in terms of the deaths, it's hard for a couple of reasons. Number one is that there's always a bias towards, if you just use health facility data, there's always an undercounting, and so we will be, luckily in many of these situations there is community-based mortality surveillance. But there will clearly be issues of quality control, and in some of these places when there is insecurity, the data may not be there. So it's always a challenge. I think I'm happy we're doing it in 3 different places, and to be able to see if we can at least find trends. And the last thing I say that we want to do, I hope that we can do this, is to get an idea of how people have tried to mitigate. So as I mentioned, they decentralized the general food distribution. They started to give 3 months worth of medications to people. It would be interesting to see, could we look at, for example, diabetic control? Can we look at antiretrovirals? Can we look at viral loads and others to get an idea if by spreading this out from 1 month to 3 months, did it work, or did actually people were in such dire straits economically, did they sell medications? Who knows? There's a lot there that we'll have to try to tease apart.
Okay, thank you. I'm going to go back to another question that Steve Ferracuti of Canadian Physicians for Aid and Relief had asked about host factors apart from age that might be protective. I don't know if you addressed that yet. And so he talked about what might be due to immune system activation. Again, that might be too biological here for what you do.
Yeah, well, certainly for what I do, but I'm wondering, I mean, there's been discussed there. I'm always careful because I don't want to start misinformation. And but there are a lot of hypotheses about what could be happening in some of the lower income countries to begin with, particularly in places of Africa. There's been discussion of those that have had BCG. Is that protective in some way? There are a lot of ideas that I don't think people know about. One thing, though, that I would say is it would be interesting to look just when you look at people of lower socioeconomic status in many of our countries who have no choice but to work and be exposed. Probably there may be a difference in host community and refugee communities in some situations where host communities maybe have a better access to livelihoods or a better social network. On the other hand, we talked about this when we compared slums to refugee camps. Refugees actually in camp-like settings, not out of camp, but in camp, they get food distribution. Sometimes it's not always enough. So there may be less of an economic pressure on them because of the reduction in economy and even some of the quarantining compared to some of the national populations. So there's all of these things that need to be teased out. The other big concern, interesting, and again, it didn't happen, is that we anticipated with the high number of cases, particularly because of again, with our modeling, we anticipated at one point governments would have to say for hospitalizations and certainly for very, very limited ICU beds, we're not going to allow refugees or migrants. It's only going to be for nationals. But that never happened because for the most part, hospitals were not overwhelmed.
Yeah.
Have not been overwhelmed, let's say.
No, thank you again. So there are a couple of questions related to the vaccine. One related to the choice of vaccine. about both the Pfizer, about the Moderna vaccine not requiring cold chain as opposed to the Pfizer, and whether that would influence decision about what might be used in a refugee setting, and also wondering about equity and access to vaccine amongst forced migrants and vulnerable populations. I'm not sure which setting Alison is thinking about there, but in terms of the choice of vaccine. And then Steve asked about the recent G20 declaration and with regard to equity and what did this have any binding or hard actions attached to it?
Yeah. So we're working with a group, they're called IVAC, with us, the International Vaccine Access Center here at Hopkins, and they know much more than I do. But I think the Pfizer is minus 80 degrees Celsius, so it's really, really difficult. This did happen in Ebola, where it may not have been that temperature, but you needed the Ebola vaccine needed very, very low temperatures. It was possible at a lower scale. The Moderna vaccine, I believe, also needs, someone maybe knows better than I do, but it's minus something. It's also quite, it also needs to be well beyond the normal cold chains. The best one in terms of cold chain is the AstraZeneca Oxford one. There's still a lot of controversy about what percentage it actually is, but regardless if it's 50, 60, or 70%, it will be much easier it'll be very similar to what we do with EPI, the regular vaccinations. So I would hazard to guess that will be by far the most important. But there's still a lot of questions about other vaccines, such as the vaccine that China has made, and it's being now rolled out in certain countries. And the Russian vaccine, let's see, there's still be a lot of questions. I think there's certainly some people feel that in some of these low-income countries, the vaccine from China may have a larger acceptance. Let's see, not because it's necessarily from China, but because of the way China is discussing this. In terms of the G20, to my knowledge, I mean, yes, people as always will speak diplomatically in those sort of meetings, but to my understanding, there's nothing that is as concrete. The best case scenario, I think, is still COVAX, this vaccine facility. But the question will be already, the numbers, I think, for humanitarian settings are going to be extremely low relative. I still think it's great that they're doing it and having this buffer stock. And then you've got this whole other issue of, even if you had all the vaccines in the world, how are you going to deliver these sort of vaccines in Yemen, in Syria, in Libya, when there's active fighting, which is going to get, particularly when you need 2 doses as opposed to 1 dose.
Yeah, no, thank you. I guess maybe a follow-up on that a little bit is in terms of, with the data that we have now, with the imperfect data showing low rates, and again, you talked about the uncertainties about whether, as we've seen, much greater second waves in many other settings, would you be looking at, when we look at the investment that is required in terms of the vaccine in these settings and the effectiveness, would you be saying that that this is where we should make investments right now as opposed to other priorities? What would you say would be priorities in terms of investment in humanitarian settings?
Yeah, that's a really good question, of which I'm hoping not to answer. The issue, there are many issues, is that even if there's a tremendous amount of transmission, but the severity is not as bad and the death rate is not nearly as bad, many of these countries are suffering very, very much economically because of the overall global effects of this. And that's number one. So that until the vaccine is, in my view, until the vaccine is rolled out, and that's going to take, let's say, until the end of December of let's say a full 2021, and if enough people accept it, and then if there is herd immunity, the low-income countries are going to suffer tremendously just economically. That's number one. I'm hesitant, and it was funny because I was corrected by someone at WHO in one of the webinars to be careful, and by saying there's a lot of people say, well, maybe we should then be putting a lot of, well, not ignoring it, but can we do other things that are some of the interventions that we're doing possibly having a larger effect in terms of deaths and mortality than COVID itself. We did see that in Ebola, as I mentioned, in terms there were many more deaths due to malaria. In Yemen, with cholera, it was the same thing. A lot of issues were ignored. I think what I would say is that you can't ignore one or the other. It's not binary, but that I think we need to carefully consider or to say that some of the ways we are doing things in Canada and the US and Europe may not necessarily be appropriate in some of these other countries, and we need to think a little bit more about the context. But I'd be very hesitant to say we should not think about, for example, the vaccines, or it shouldn't be prioritized in those countries. It's complicated, and I don't think I have a very good answer.
Maybe along the same lines is another question. Is the mortality rate low enough to consider restrictions such as physical distancing as being actually more detrimental to the population than the disease? You alluded to the fact that typical distancing measures are difficult and maybe impossible to actualize and to allow people to survive.
Yeah, that's where I think we will need. I mean, firstly, overall, when we look, there will be so many lessons learned and so many mistakes we've made in our countries right now. And I think a lot of this, for example, the R0 and how we were looking at the transmission and over one, or was it going to be 2 or 3, not really taking into account the idea that it's not linear, it's not a standardized way of transmitting, and therefore not looking at the stochastic and unpredictable ways. I think that we will, in the future, when we have to deal with something like that, think quickly of when is the best time to quarantine, and not necessarily do everyone follow what China and then Europe and then America did. But it made sense at that time. And there's still a question. Many will say, well, it's not as bad in some of these countries because they actually took strict measures early on. That may be a valuable, maybe a worthy argument. So it's a bit too early to say, but I think there may be ways, especially when we understand a little bit more about the seroprevalence, to at least better understand and rethink some of the policy implications that we did do in some of these countries.
Thank you. Just for the audience, we should be able to get a couple more questions in if you haven't already asked things, or if you wanted to make a comment, please do so in the Q&A chat box. But we have a question about research, and this is from a professor of environmental studies, very much into participation. So talking about what strategies are used for improving trust in researchers, so people in these communities are willing to come forward, share information, and get medical assistance. And I'm going to add to that about involvement of refugees themselves in research right from the beginning, in terms of what their priorities are, whether there's a movement to trying to decolonize research in that way. Yeah.
Again, really important questions. Let me think of 2 or 3 things. Number one is it's how we have to go about research now is we have to be so careful that we don't exacerbate transmission, and we always have to be like that. But with a respiratory borne virus like this. So how we do research will change. And I'm sure, like in many universities, we have very strict ways now of how we can do it. And currently we can't do it. We're just now probably going to be able to start traveling. I think that there is, I think this pandemic, there will be a lot of positive things from it. And some of it may be this idea that we don't need to travel in the same way, that we can do some of this research with local researchers. And so there may be some silver linings despite all of the pain. Working with refugees. So when there's always a problem of how we develop our proposals with Western donors and how do we get input from refugees from early on. Normally what we do, at least what I do as a researcher, is we work with the NGOs and always with maybe with the government, with the UN, but with the NGOs, and trying to work with national NGOs. And then it's incumbent upon them to hopefully understand the situation, whether they have and do, and we never do it enough, of work with the refugees. I would say in the proposal development, certainly their qualitative components are always there. And so we're always doing that when we're there, but to have a better way to be able to actually work with the refugees or any affected populations, humanitarian populations, to get input into their needs and to get input of the way to actually go about doing things, and improving the methods is something that we all would like to do, but I don't think do it very well.
I wonder if you could elaborate a little bit more about governments abusing the crisis as a chance to increase control over populations. So the use of public health in humanitarian settings. I know you alluded to that a little bit, but if you might elaborate a little bit more.
Is that specifically public health in terms of meaning the way public health has been abused to make things worse for certain populations?
Yeah, yeah.
Sadly, I can speak more from what's been happening here in America. And I also do understand what's happening a little bit in Venezuela. But I'm sure many of you, if any of you work in Venezuela or Colombia, will know more than I do there. But I'll start here within the US. It has been so politicized, and I'm sure you're all reading, as we are, what's been happening. But one of the more, let's say, sad situations is to have something like a group like the Centers for Disease Control be compromised. And I worked at CDC previously, and many of my friends there are not at all. They were very strong and very strict, and some who I won't name refused to actually put their names to the March order, and then the July order outright refused. But has been such political pressure, particularly on the leadership on Redfield, that I think there will be long standing harm of credibility to the CDC. What's hard to really, for me at least, to understand is how. So I would just say it's all, from my point of view, it's political, and it's not I don't think anyone that was writing these orders I think they knew, and I have some insight, but not a tremendous amount because I don't have access to those people that are writing the orders in the administration, but it was a very clear and deliberate. It wasn't to say we're going to help the American people, and it was a way to say, how can we use public health and how can we take advantage of a pandemic to achieve our goals of reducing immigration in the US. And that's what's happened but on the other hand, and I'll stop here after that, is that we're now working with Human Rights First and others to try to give recommendations, as I mentioned, to the Biden administration. And it's easy to say when you don't have a lot of people crossing the border that you should be testing everyone, and you should not put them in congregate in detention centers, but rather you should be, many of these people have people outside within the US, relatives or friends, and they can go there while they're waiting for their asylum hearings. It's easy to say that when you have fewer people crossing, but when you have tens or hundreds of thousands of people crossing, we're still trying to figure out what is the best way to both take care of the American public health and avoid people in congregate settings, but there may not always be choices at times. So I just wanted to emphasize that, well, we can come up with interesting ways and recommendations. I saw this when I was at UNHCR. We often get a lot of recommendations that don't really take into account the context and the feasibility.
And Mary Louise would like you to elaborate a little bit more on the positive signals that you see from the upcoming Biden administration, both in terms of policies within the US, but also perhaps internationally with regard to humanitarian assistance.
Yeah, I mean, there have been some dark years here, and I mean, already Biden his administration has said that they are going to be dramatically increasing refugee resettlement. I know the number, but I don't want to state it in case I'm wrong. I think it's like 100, but I think it's about 120,000. But he's going to dramatically increase then refugee resettlement. Number one, he's going to, and the courts have just rejected it recently, but with the DACA, with the Dreamers Act, he's going to allow the Dreamers to stay, and that's been a big problem amongst all of these, the DACA recipients. He'll be rejoining the World Health Organization, as we know, and I'm by the way I'm not that involved, so I don't have inside information with the Biden. So a lot of what I'm saying is public. But what will happen in terms of immigration reform in this country will be interesting to see. I don't have any insight into it other than to say that it is extremely complex, and I think people should not be naive to think that now that you have this administration, a lot of these problems, which we're not able to get immigration reform in this country with Obama. Even if there was a Congress that actually could agree on certain things, it's a very, very complex and thorny issue, which is not going to make either side happy, I think, and how you're going to deal with it with migration. And a lot of what you do has longer term effects of how people and migrants may wish to come into the U.S. as well. So it's a very, very thorny issue. So bottom line is I'm very, very hopeful. On the other hand, I don't think that he's going to come in and suddenly it's going to be just like it was. We're in a different part. We're different now. It's different. Things have changed. The country is so divided, and he needs to think about all of America. And if he moves to do too many things that I think many of us would like, he may lose another part of the country. So I don't think it's going to be a panacea now that he's coming in.
Another question on I believe it's more about advocacy and the implication of NGOs and or institutions such as the WHO and UN to defend access to COVID-19 vaccines to the most vulnerable in LMICs and those in war zones. So just wanted you to elaborate on perhaps, I guess it's what the impact of this would be, what type of position statements or policies would be most effective for NGOs. And thus far, I guess you already mentioned about the G20 declaration, I believe.
Yeah. I mean, WHO has been open early on, which is very good to say equity. We need to start thinking about this early on. And so I guess I've become a little bit more cynical in terms of, I'm very glad that WHO is saying that, but with a pandemic, and this is the first one that I think most of us, if not all of us, have lived through, you see the limits of what multilateral organizations can do, and even NGOs and advocacy, because you have governments that are going to be acting selfishly, and it's so what a difference it was in trying to respond to Ebola than it is trying to respond to a pandemic. You just can't, and particularly a pandemic with a respiratory nature. And so while we can all scream about equity, many of us, and my mother and my sister are in Canada, and I hear that there are a lot of concerns about how the vaccine will be rolled out there and the quantities and everything. And you can imagine, I guess one can imagine, in many countries, if a government says we won't take a certain amount and we're going to be giving it to some other countries, I think that's going to be politically extremely difficult. And so, I think we all need to. It's incumbent upon us to advocate, and I hope that we'll have some effect. And there is this COVAX buffer, as I mentioned. I do think at least at the beginning, and we saw the same thing with HIV as well, for antiretroviral therapy. Countries are going to, I think, concentrate, and they have a concentrate on themselves and their own nations at the beginning until there's enough. And I think as soon as you can get herd immunity in the high income countries, it'll be a completely different game. But that's my cynicism speaking, and I hope to goodness I'm wrong.
I think as we're moving to wrapping up, I wonder if you have any lessons for us as an institute, just because we comprise academics, health professionals, advocates, some research and policy people. And I just wonder how you see perhaps this, maybe not quite as an opportunity, but what you see as the way that we can work best in all of those domains with the current situation.
Hard question, but I would say one thing that I like that you said is that it's, I take it from a public health perspective, but I try to be broader. And the multidisciplinary nature of your institute is really important. My question is, how well do you speak amongst yourselves and share views and actually try to get the multidisciplinary nature? I mean, Hopkins is huge, and I've been trying to work with SAIS, which is the School of Advanced International Studies in Washington, D.C., but it could be in Kinshasa, as far as I can get to it. So I'm now, and the pandemic just exemplifies this, but we can't just work as Johns Hopkins School of Public Health, looking at public health issues. It's so much wider, and even a public health or a pandemic, which one would think is a public health issue, is so much broader than that. It includes all different aspects, from economics, anthropology, etc. So one way is it's rather more of asking you is, how do you, with a multidisciplinary group, actually try to look at a problem, each from your own way, but to make much more of it? And then the second thing that it's really a challenge, because I certainly haven't succeeded, is how do I imagine most of what I've said tonight is supported by people because they probably wouldn't be tuning in. But how do we get to the people that don't support what we're saying, that don't think migration is important, or that have big issues with giving vaccine to people in Syria, for example? How can we start reaching out to these people in a better way? And that's all just end by saying, that's why sometimes I think it's good that we publish commentaries in the Lancet, but I think most people that are reading those already agree with it.
Well, thank you, Paul. I think now we're moving into the concluding aspects of tonight, and I will, before I thank Paul and Jessica also for doing the introduction, I would like to remind people that you can contact us through csoveral@icloud.com, the particular email that you used, if you want to get more involved with our institute. Then we have sessions every 2 weeks, beginning in January, beginning at the end of January. And thank you, Camille, again for putting this up. So we have Marcel Boekeboom, who's the climate envoy of the Kingdom of the Netherlands, and Courtney Howard recently was third runner-up, or second runner-up, I should say, in the Green Party leadership debate. So a physician getting engaged on environmental issues. we thought that that would fit well. That's at noon on January 27th, really to manage European time. So we're hoping our institute will also be accessible to people around the world live. We will be putting presentations on our website, and people asked about our last presentation with Ingrid Waldron on environmental racism. That we should get up early next month. We have Michaela Henia and Meb Rashid speak about refugees again, but within the Canadian context. And Meb, as a physician advocate, led efforts to reverse a very poorly thought out government policy back in 2012. And Michaela is a researcher who does stuff that really is groundbreaking in terms of advising about policy. Most recently, we were involved in a study of Syrian refugees who came in the immediate period after 2015, and we followed them for 4 years. But she's engaged in a lot of refugee research in Canada and around the world. So that'll be February 24th. We may have one other presentation in between there. And then March the 10th, Andy Haynes, formerly the head of London School of Hygiene, in charge of different Lancet panels on climate change and on global transformation. I guess it was the chair, the Commission on Planetary Health. So a climate advocate for many years, likely speaking with the head of the Youth Climate Lab. So getting people with lots of experience and people who have lots of energy, getting youth involved in their future. And so we will try to do these presentations every 2 weeks. So please do take some time to complete our feedback survey if you're able to. And I should say once again, Paul, I learn from you constantly, and I think others have said that too, others in the refugee community. We can hear you 10 or 15 times, and we continually will learn from you from the experience that you've had in so many different contexts. And we appreciate the fact that you're Canadian and a graduate of one of our medical schools. But your advice, I hope we can continue to rely on with our institute as we move towards different types of actions. So thank you again, Paul, for this, and Jessica also for introducing Paul. And
thank you.
So stay healthy, stay safe, and continue to take care of each other in these very interesting times. Good night.
Good night.